Okay, so Partha.
Hello, good morning. Good morning.
Good morning. I have some questions to ask you.
Go on then.
Okay, so we all know that you love comic books.
Mm-hmm.
Who is your favourite Disney princess?
I would say Rapunzel.
Oh, and why?
Don't know, just like long hair, I suppose. But no, I think I like the story. I like the story of an independent, I mean, all of the princesses are quite independent, but I just like the story behind it. I don't know. It's something that stuck with me. My daughter used to love it, so I probably saw it about billions of times. So that always sort of gets in your head. But yeah, I think that probably would be top of the list.
She does have excellent hair.
She does. Can you imagine having to brush that, though? That'd be a nightmare, wouldn't it?
It would, especially, well, I suspect a lot of people have had training and all that in COVID times with their hair and everything. So yeah.
Your own hair, COVID hairstyles.
I wonder if she uses L'Oreal shampoo like you, Partha.
Well, I don't know. I tend to sort of borrow a lot of her shampoos and conditioners. So who knows? It's the other way around, probably. Yes.
Fair enough.
Okay, next question. If you weren't a doctor, what would you have been?
Primary school teacher.
Oh.
Yeah. I love.
You were going to say Iron Man or something.
No, primary school teacher. I've always wanted to be a teacher, and I love kids. So that definitely would have been top of my list. So wow. I'm very jealous of people who do that because it's just fun, I think. I don't know whether I would teach them anything, but it just probably would be a lot of fun.
Why didn't you choose peds?
I did train in peds. So I've always said that, two or three of the specialties I really have a lot of respect for because I wouldn't be able to do their job. And I tried and I couldn't, was peds. And the other one is NE. So pediatrics, I really struggled. And I just, I think the kids being ill was very, very tough for me.
Yeah.
So I did that in India where we've had some, as you'd imagine, because of the issues and finances, etc. There were quite tough things. And it just put me off. I couldn't do that. So I think emotionally it was far too much.
Yeah, no, that's sad.
Right, I think we're ready for your COVID-19 facts and fiction.
Okay, so yes, I will share my screen. So here's our first attempt at technology this morning. So first of all, we've crossed 100 people. So thank you very much to everybody who's joined. And I think I will also say a special thank you to obviously Beth and Amanda for the work they've done, and also the rest of the team. I mean, everybody, as I've said, and a couple of things just to mention at the very beginning before we start this, is that first of all, this has completely been voluntary. So everybody I've asked, and Sam, Nusrat, Hannah, Vicky, all of them, everybody names you see on the list, it's been completely voluntary, and that's been really, really much appreciated by myself, I would say. And one of the things we as clinicians always get a lot back, and you will see a lot of that, is that, so what is this connected to in the sense? Just to clarify, there's been no money has been exchanged. There's been no pharma involvement, nobody. This is purely on our own time. And a huge thank you to Becky Thomas, or Rebecca, as I call her, for facilitating this whole session that we've got. And helping us to get the Zoom link. So it's completely voluntary, and I think it's quite important to make it clear for future reference as well. Right, so sharing of screen, which is going to be the first technological thing we shall try this morning, and there is a decent chance it might work or not. We'll find out very shortly. And let me know if you can see my screen. Yep, good, excellent. So I think what I want to do in this presentation is all of you who are attending, and I know a lot of you probably have diabetes or look after people with diabetes. This is not a session designed to scare anybody, but I think just to sort of try and sort of unpeel some of the myths and facts which are out there, some of the data that's out there, and some tips from my end as to what probably would be advisable, what we as healthcare professionals are advising people to look into and do. And during the course of this day, obviously Rose will be touching upon the whole mental side of it, which has been a big impact, understandably, during this time. So this is more about what facts there are. And just for clarity, there'll also be opportunities for Q&A. So if we can't answer them all, we'll record all our answers. We'll put it up on YouTube. So feel free to ask any questions you would like to. So first thing to start off with, these were some of the first studies that started to emerge from China, where it started off, obviously in Wuhan. And there obviously was a lot of conversation about diabetes being in the background. So that started off some of the conversation. So when we, at that point of time, we started looking at some of the data, we anticipated that people with diabetes may be at higher risk. That was simply because people with diabetes have increased risk of infection because of the innate immunity defects. It's linked to hyperglycemia, both acute and chronic. That's well recognized. That's pretty much why we have this whole scenario whereby we have people with diabetes being given the flu vaccine. We tend to look after inpatient diabetes. There's so much investment or time into it, simply because we would like to get people blood sugars in a good region so that infection, harmful effects are less so. And what we knew at that point of time, based on data that was coming from China, followed by Italy, and then Spain, that age and obesity were main drivers. We didn't have much data available on the type of diabetes at that point of time. So our response at that time was, okay, we'll try and prioritize services. We said we would leave foot clinics as much as feasible on, and we'll leave pregnancy on as much as possible. Again, keeping in mind the overall infection risk, but most importantly, because neither of those two conditions were going to go away. So, and the long-term impact of that was going to be quite important as we went along. Inpatient diabetes services, we asked very clearly to hospitals to make sure that people with diabetes coming in were looked after. At the end of the day, I think for a lot of people on the call, just to make it, so we can't make things mandatory. We can nudge, we can push people towards, we can issue guidelines. But in general, that seems to have worked, and we have asked for more and more virtual support as much as possible. Now, I know at this point in time, some people will say that I haven't had any contact from my diabetes team, and there will be different levels of pressure on the system. All I can say is that lots of areas have. For example, where I am in Portsmouth, we have tried to keep all our clinics going, even though by phone and videos as much as possible. So that was a starting point, and then we some information from London. So one of the big things was we had a very good core group, and a big thank you to colleagues based in Bartholomew's Hospital, Royal Free, Guy's and St. Thomas, led by a clinician called Dr. Stephen Thomas, who collected a lot of information as they were coming through from London. And it basically said that what we were picking up, a lot of doses coming in with type 2 diabetes. Fluid replacement, we had to be looking at, so sorry about the jargon, medical jargon, but in simple plain terms, we need to be careful about how much fluid we were giving people when their insulin requirements were high, and type diabetes patients were quite high on insulin. So I think the important point of this was we had a group which was feeding us with information as things progressed, so that the rest of the country could be a bit more prepared as to what was coming along. So these are some of the advices that came out. So those of you who would like to look at it or would like to show it to your local teams, if you want to, if you just go to the Diabetes UK or ABCD, there are a host of these guidelines out there. One is about people being admitted to hospital. One is about people being looked after when they're in hospital. And then there are people when being discharged from hospital. So I think the whole point is to try and guide people. Now, local had different policies, they might be better policies, but this was about having a national guideline during these times. And there was a national group set up of doctors, pharmacists, nurses together who tried to create this guideline, which has been used by many, many centers. Then to the data, and just a quick point to make. Those of you who have just recently joined the call, if you wouldn't mind just muting your mic so we don't have to hear background as we're going along, so that'd be great. But just to say, so this is the first slide of data that came out. So I'm not going to try and don't worry. So this was more about simple things. It looks like a bit like a picture from Star Wars. We've got different TIE fighters flying all around. But let me try and explain this in simple, plain terms. See the middle dotted line? The more closer to that you are, the better your risk. So the one lone TIE fighter, so to speak, which is way outside, as you can see on the left, that's the age, right? That sort of shows that if you are below a certain age, and you can see the age there, your risks are quite low. And as you can clearly see, the further out you are to the right, you can see as your age goes up, your risks go up. So this was the big data done by Ben Goldacre. And I think it also shows the importance of obesity, which has been discussed a lot. But just to draw your attention, this particular data set did not have anything on types of diabetes. It simply had diabetes, and you can see there is an increased risk. It's away from the dotted line. And it also showed that if your HbA1c was more than 58, then there was a higher risk. So it was very binary. There was one cutoff, there was no structure, but all it said, if you got diabetes, you've got higher risk, and most importantly, if your diabetes control is more than 7.5%, you've got higher risk. Now, people always ask the question, shielding, right? So you can see from this group is that there are two groups there which stands out. One, the people with hematological malignancy, which basically means things like myeloma or leukemia, etc. And then there's organ transplants, so people who have had kidneys replaced or liver, spleen, whatever. You can see their risks being far higher out, which is why they were in the shielding group. And I'm sure I'll touch upon the shielding side of things as regards diabetes, because that has sort of generated a lot of questions as to who should have been shielded, who should be shielded, etc. So this was the first data that we did. So we said, all right, we know that diabetes is a higher risk. We know that higher control, or poorer control, so to speak, or HbA1c more than 58 could lead to higher risk, but let's try and sort of define it. So this was the first paper that we did. And what we did is we looked at data which was available of in-hospital deaths, which occurred, unfortunately, between the 1st of March and the 11th of May. And what we did is we looked at this data. And as you can see, similar concept to what I explained. So you can see that what the risk is below the age of 40, really, really low. And then it accelerates as it goes higher up. You also see the difference between male and female. And then as you go down, the important bit there is socioeconomic deprivation. In simple plain terms, the poorer you are, the worse your chance of survival. So that's the fundamental part of the whole COVID thing. It shows more in stark nature the differences in society. Similarly, if you can see this, the ethnicity made a difference. But this was the first paper which shows the difference between type 1 and type 2 diabetes. As you can see, there is a difference between the two, and I'll come back to it about what that actually means. But again, just to emphasize, I think recently, yesterday or day before yesterday, I've seen a paper come out in the United States showing high percentage of poorer outcomes in people with diabetes, but doesn't, again, I mentioned the difference in types. So this has been one of the first papers looking at the types of diabetes. This was about what we saw. And again, I think just to also make it very, very clear is that one of the questions we have, as soon as we said that type 1 diabetes seems to have higher risk. Quite understand, we've had lots of parents, lots of carers saying, what about my child? What about my son who's going to university? What about them? I think it's very important to mention that the risk below the age of 40 is very, very low. As you can see from this graph, the risk actually goes up from 60 upwards in type 1, which is the red bar. Type 2 pretty much across the board again. 40 years, it seems to be the thing. And that sort of goes back hand in hand with the whole debate about should they go back to school. So I think the message, overarching message is, yes, there is higher risk, but to bear in mind, the average age of death in type 1 diabetes was about 72 years. And in type 2 diabetes, it was 78 years. So higher age groups, that's not to say that are we trying to scare people who are older? No, that's just data as it is. This is a particular virus, and forgetting diabetes for a second, which does tend to affect more inversely or more adversely people who are in the older age group, which is why the whole point about trying to make sure we look after our elderly and all these discussion about masks, etc., is not just about ourselves, about protecting the vulnerable of the society. This was another piece of work. We said that was a very simple question we wanted to answer was, has the rate of diabetes overall gone up? And you can see data from 2017. This is the death rate associated with people who have had diabetes over the years. And as you can see, you don't have to be a scientist or a research person to tell you, you can absolutely see a jump from April onwards. A lot of them in care homes, which has been well documented, but it certainly did happen. And this data is across the board. It's all everywhere, and not just people in hospital. So some of the salient points, I think, and as I've mentioned, and as you mentioned by Beth and Amanda, these are all being recorded. This will all be available, so you can take your time and go through it, and we'll take questions if you have further questions. So people living with diabetes do face a high risk of dying with COVID-19. Type 1 diabetes does have a higher risk than type 2. Strongest risk factor for dying with a virus is age. And I think it's very important to bear that in mind. So help us show with young children. We have said, as I've said, higher blood glucose levels and obesity linked to higher risk. According to the data we have had, too tight control or too low BMI was also associated with increased risk. Now, the important point to say, we have had lots of questions say, so if my diabetes is really well controlled, let's say my HbA1c is 5.4%, should I just lessen the control? The answer to that is no, because don't forget, this data might also have elderly people who have been very frail, who might have had people with background malignancy, etc., as a result of which their overall diabetes control, so to speak, looks really low, but that's because of frailty, not because of simply of their control levels. Both type 1 and type 2 diabetes, socioeconomic deprived communities, and people of ethnicity were high risk. And I think it's an important point to mention that if you've got pre-existing kidney disease, heart failure, previous stroke, you were at higher risk. So the message here is not to scare anybody. The message here is to say, what can we do to protect people going forward as things are? And I think a fundamental part of this is to say that if you have type 1 diabetes, for example, your risk is lower with lower age, but it does exist at a higher age. And I think it's important about what we can do to try and counter those. So what is the response to the data? There's been a national advice helpline via Diabetes UK. I'll give you the number in a second for those of you not aware. So that's something built with professionals in case you are not able to get in touch with your local clinical teams for in cases of emergency. We have got a type 1 diabetes education and self-management platform out. If you're between 0 to 18, it's with DigiBeat, it's free. If you're more than 18 years old, it's via My Way Digital, it's also free. Please do log in, register, and use it as you so choose. For people with type 2 diabetes, there is a similar platform coming out, hopefully in the next week, if not just after. But that's also going to be free and available to everybody. The whole point being, we're trying to lessen your having to go somewhere for face-to-face. So you can do that in your home as much as feasible. Shielding, we have had lots of conversations about shielding. As you very well know, the government's position has been to actually lift the shielding. From August, nobody's going to be in the shielding category. However, one thing that is coming through is a risk calculator, which is being developed by Oxford, and our team will be looking at the risk calculator, trying to validate it against the diabetes data. So you'll have a very simple open access where you can put in your own data and you can find out your risks of having poorer outcomes if you have COVID-19. It's a bit like what we use for cholesterol, etc., in the system. And that should be quite helpful for people having a conversation about, should I go back to work? What should I do? Should I shield, etc. That's the national helpline. If you don't have access to it, it's 0345123239. It's been done in partnership with Diabetes UK and industry as well. So it's something which is, again, free if you so want to use. Some relevant issues to mention. Risk calculator, I said, it's coming through via Oxford. It will be made publicly available. So hopefully in the next 2 to 3 weeks, it should be available for everybody to use. And hopefully we can avoid using it in case we don't have a second wave. This is to see that what would we do if the infection rate starts to rise again and we do look at the possibility of a second wave. Big question around work. What do we do at work? I don't know whether you've seen, there is a particular website done by occupational health physicians. It's called ALAMA, A-L-A-M-A, and it talks about the concept of COVID age. You can have a look at it, but the risk calculator should also help you having the conversation with your employers as to, it depends on your risk levels, whether you should be at work if the infection levels go up to that level or not. The position on schools is very simple, which is supported by the associations of pediatricians doing diabetes, especially, and the Royal College of Pediatricians. We do say that children should be going back to school come when it does open up again. So because of the low risks involved. Dexamethasone, as you know, has been a big topic because of the data that's come out. And the important message there is that we are aware that dexamethasone has an impact on your diabetes control. And we have a guideline out and ready on a national basis for people to be, how their diabetes should be controlled, what doses of insulin, what needs to happen inside a hospital in case they do need it. So that's also ready and it's on the website of Diabetes UK and ABCD if you so want to have a look yourself. But it's available and ready in case there is a second wave and we need a lot of dexamethasone. But as I said, fingers crossed, hopefully that's not the case. And finally, vaccine, lots of conversations going on about a vaccine, as you might imagine. I can assure you, for those of you listening with diabetes, that is firmly within our sites in NHS England. We are part of that committee. We have made the case as regards where diabetes patients should sit in there. And the push will be for people with diabetes to be prioritized. And so that's something we are working on. And hopefully the data will support what our position is on that. So finally, to wrap up, I think the important point to say is that, reassurance to all with diabetes, because there are I always talk about modifiable and non-modifiable factors. You can't modify your age. You can't modify your ethnicity. And socioeconomic deprivation as to how poor you are is probably a semi-modifiable factor, probably more in the hands of governments rather than ourselves. But it's important to bear in mind the modifiable factors, which is glucose control and weight. Now, it's very easy to sit behind a desk for us healthcare professionals or clinicians to say, you should do it. So I won't say anything like that, but I think it's an opportunity using some of the online platforms to try and see what you can do to try and improve things. That's all I can say as regards that bit, but appreciably it's easier said than done. I think the media outlets we have used to try and provide a consistent message, whether it's via video or blogs or any media and stuff, and I appreciate the media don't always report it as simply as possible. But we have tried as much as possible trying to hit all the national media outlets to try and give a consistent message of it is what it is, but we are trying to help, and it's not across the board. The risk factors are not the same for everybody across all ages, etc. We are continuing to look at data to pick any obvious triggers. That includes what medications people have been on. So is there any medication which makes things worse? We're keeping an eye on it. At the moment, there is no such signal, so to speak. Is there any medication which makes things better? We're also keeping an eye on that as well. There's a coronavirus support app which is out. You can download that. It's free if you want. There's a section on diabetes which gives a lot of information in one place if you so choose. And as regards the important thing is prioritization messages are going out as to what systems should do. Clearly people with higher HbA1c to be tried and see what we can do to try and improve their control. But I will finish with one final thing. The best weapons against all of this still continues to be three things, which is social distancing, hand hygiene, and masks. And I know there's a lot of controversy about masks, but just bear in mind what we are trying to do and where things sit and what we can do to try and take things forward. So try and stick to what's there. The UK have made huge progress, but at the cost of many, many lives as well. So hopefully we can avoid a second wave and thereby avoid using any of those articles or protocols, as we have said, and we don't need to do any further data crunch, etc. So I will finish there with the simple message to anybody listening with diabetes that the NHS is here for you to try and help you as much as possible. We are also have got many, many things to sort of try and handle at the same time, but a lot of the responsibility is also with everybody out there. If you've got diabetes, try your best to try and do the social distancing, hand hygiene, and mask as much as you can. That's me done. Thank you.
Thank you very much, Partha. So the questions have been coming in thick and fast. We do have quite a few to go through. So I'll start and then Beth will continue after me. Okay, so it's good to see the risk of death being low for younger type 1s, but what about the effects on ketones, etc., of being ill with COVID? Is the first question.
So what we have seen, so one of the theories that's going around is whether it itself has provoked type 1 diabetes. There's not much science out on there. There's a lot of theory, speculation. As regards ketones, we've seen a fair bit of that in a type 2 rather than type 1. That's from what we have picked up. But the message is very simple. If you're not well, check your ketone. That's the standard part of any sick day rules. And I think that's what I go back to about following sick day rules. There is no better time to sort of look at all the sick day rules, which are available very widely on NHS England website, Trend and all the sort of websites. So follow those sick day rules as regards ketones go.
Yeah, we can maybe ask our tweeting team to tweet out the 6-day rules again if anyone's not aware of 6-day rules. But I think 101, we spent a lot of time putting those out at the start, making sure that everyone has those. Okay, so another question we've got for you. Where will we be able to find the risk calculator when it comes out? And thank you for the information.
Yeah, so the risk calculator would be made very public. It will be all over the media. I suspect there'll be a very simple website which will be available to all. So for example, I give an example of what we call the Q-Risk 3, which we use for cholesterol, is publicly available. And this would be a very similar format because the population needs to be able to access it and use it accordingly. So I suspect that's how it will be made available.
Yeah, I suspect GPs and stuff will be having it in surgeries and stuff like that.
Yep.
So.
Yeah.
Okay, this is a message. We are strictly social distancing from everyone. My DD is 10. Is she okay to see friends now, socially distanced? Keep her away from supermarkets, etc. this whole time. Is it safer now that people are wearing masks?
So the short answer is masks. The whole point of masks is to use it when you can't social distance. And I think as more and more people go out, social distancing becomes more difficult. So I think what I would say is that looking at the infection rate, there are some really good websites out there. And if you just Google it, you'll find it, which gives you an idea what the infection rates are where you are. And I think that's where your decision point should be. So if you look at NHS Digital, you can break it down into your own region. It will tell you what the infection rates are. And if it looks really low, and as a lot of areas are low, then you should feel a bit more comfortable about going out. But again, as I said, with the masks and the hand washing and trying to social distance as best as you can.
Yeah, cool. Okay. So another question for you. So have admission numbers for children with type 1 diabetes and COVID risen? Is a child with type 1 and COVID more likely to need hospital assistance, or is this bit of a how long is a piece of string scenario?
Well, there's a mixed picture here, because I think when the NHS started this message at the beginning, which says, protect the NHS, the whole population did that. And this is across the board. We have seen, we have all wondered where our heart attacks, strokes, and all the patients have gone. And I think there is a lot of worry, quite understandable, among pediatricians about type 1 diabetes presenting later or more sicker. That may or may not be due to COVID. That may be the fact that people have avoided coming into hospital because of the messaging, as well as the fact that people have been worried about coming to the hospital, simply because they would see that as an area whereby there's a lot of COVID-19, so why expose the risk? So a bit of a chicken and egg, and that's quite rightly too. But there is a lot of messaging out from the pediatric communities that they are seeing higher admissions, and thereby please be aware of the 4 Ts, please be aware of sick day rules, and please present to the NHS if you're worried.
Thanks. Okay, a couple more. Is a person with type 1D who has had proton beam treatment in the last 3 years for melanoma in the eye in the higher risk category? And then there's another question that's quite similar. Are people with diabetes more likely to catch COVID?
So I'll do the second question first. The answer to that is we don't know. I think so far there is no indication that people with, it's again the chicken and egg. Are you coming in and thereby having worse outcome because you have diabetes, or is it because there's nothing at the moment, as far as I'm aware, to suggest that if you have diabetes, you can catch it more quicker. As regards the first question, somebody who has had melanoma of the eye, I would suggest probably picking that up with the team who's looking after that. I think malignancies are in there. As far as higher risk, I suspect a combination of both will make it a slightly higher risk, but I probably wouldn't hold my word for it. I would definitely talk to your oncology team or whoever's looking after that side of things to see what they say.
Yeah, cool. So we've got time for one more before we go to the next speaker. Yeah. So I think, is the coronavirus support app made by expert self-care people or the NHS?
So a combination of, there's patients there is a lot of people, again, who put in some voluntary time, so clinicians. So the diabetes bit was done by me, and all I have done is just linked it to all the resources I've just mentioned. So for example, if you go into that app, you will see lots of different specialty areas, but if you click diabetes, you won't see anything different than what you're seeing in lots of other places. It's basically everything in one place. That's all it is. So yeah. It's just on your fingertips on a phone. That's it.
Yeah, it's a lot easier to have it just in one place, isn't it? There's one more on there, which is probably quite a good one. If you're a type 1 and you're working, you've got high HbA1c, but you're unable to maintain social distancing, what advice would you give these people?
So 2 things will come into play in here. So again, I mentioned about the website, which is called Alama. So you can have a look at that, which is done by occupational health physicians. So I'll give you, so locally we have got patients who've got type 1 diabetes working. So 2 or 3 things will come into play. What is your control like? What is your ethnicity? What is your age? And which area are you working in? So there's a fundamental difference between, let's say, working on ITU and working, for example, in a back office. There will be a difference about the risk level. So I would use that website, have a look at it, and you must absolutely have a review with a clinician who looks after you to make a decision or help you come to a decision whether you should be working or not. We certainly have done that in Portsmouth, where we are with all our colleagues who have got type 1 or type 2 diabetes.
Oh, great. So just to let everyone know, all of the questions that we haven't managed to get to, we'll gather them all up, and we plan on asking them to Partha and the rest of the team who it's relevant to, and we'll try and get them out in the next
we'll do it in a podcast.
Work depending. Yeah, hopefully we'll do a podcast.
Yeah. Brilliant. Thank you, Partha. You're free to go.
Thank you very much. Thank you. Take care. Bye-bye. Bye-bye. Bye. Bye. Bye.